easier part, I would say, of treating these patients is the procedure, and the more long-term, harder part is the follow-up regimen. At our, we've stumbled through a lot of this in our practice, and what we've found is that if we put a stent in, we're going to get a CT at either 1 or 3 months, and then 6 months, and then a year, and then yearly thereafter. And that helps us to see if there's any issues with the stent, there's any in-stent stenosis, thrombosis, or whatnot. We are shying away from ultrasounds, but we still have it in our protocol to do it at 1 or 3 months, 6 months, and then yearly thereafter. We found that oftentimes it is, sometimes if there is incomplete clot clearance for whatever reason, it confuses the people that are reading the studies. So my recommendations have a strict CT protocol. And if it's FemPop, then you can rely on ultrasound for that. But make sure you have some sort of imaging follow-up. And then anticoagulation. It's going to be a DOAC for 6 to 12 months plus aspirin or Plavix. If there's a contraindication to DOAC, then we will give our patients warfarin. And a little off topic, but if it's a nibble lesion, then we'll if you're stenting a non-thrombotic patient, then we give them a antiplatelet agent for 3 months. And what we found is that our rethrombosis rates at our institutions between 2 and 3%. And the reason is not just because of the procedure, but because of the follow-up regimen also. So you need to make sure you have both things in place. And you've heard this phrase before, but really during the procedure, really focus on taking out as much clot as possible. Leaving clot is not great, and clot begets clot. This really illustrates why we like ClotTriever so much. You get the wall-to-wall apposition. You can treat anywhere between 6 and 16 millimeter size vessels, and it really does a fantastic job of clearing out clot. And the way to really to test this out is use IVUS if it's possible, if it's accessible in your institution. You're going to be able to see how much clot clearance you have. And so for this reason, we are using ClotTriever primarily. We've shied away from other forms of aspiration thrombectomy due to the possibility of not clearing out as much clot as needed.
One thing that I've really taken from this data, there's been a lot of things flying around about valvular damage, and even though 0 studies have shown that there is valvular damage, there's been 0 evidence reported in the literature of valvular damage. I think that now that we have CLOUT data that goes out to 2 years with the best PTS rates that we've seen in any study, just curious what Raj and Steve, to me, the valvular damage argument is dead. It's over, it's put to bed. If there was clinically significant valvular damage with this device, we should not be seeing PTS rates better than ATTRACT and CAVA. Just want to kind of get your guys' inputs on how you kind of interpret the data. That's my interpretation.
Yeah, Andrew, I agree with you. From an anecdotal standpoint, before the CLOUT data came out, and even before the CLOUT 2-year follow-up data came out, we know that there's no valve damage, and we know that our patients are improving, and that's based on physical exam pre and post-procedure based off the Villalta scores. And if you see patients improving in their PTS symptoms, then their valves are not damaged or destroyed or whatever word you want to put to it.
Right.
We just know that from fundamental knowledge of venous disease, if you have a patient that is improving clinically, especially with PTS, and you're following them up, you know that there's not valve damage or vessel injury.